Hi, good afternoon to all. I think seeing the crowd here, I'm really happy because when there is an audience, then only the speakers will have an enthusiasm in talking. I'll be going fast because we are short of time. What is hemorrhoids? It is prolapse of anal cushions. Initially we were thinking something was growing bigger there. No, it is just prolapse that is happening. Even now the debate is there whether it is enlargement of hemorrhoid or whether it is prolapse of hemorrhoid. It is otherwise called piles. I think internal hemorrhoids, which is seen inside, external hemorrhoids, the skin tags, papilla, hypertrophic papilla, which is happening in fissure. They are differential diagnoses of this situation. Also, we have to be aware of situations like this. These are not hemorrhoids. These should be dealt in a different manner. Always think about polyps also, because after, just like Ladukar sir told about fistula, lot of biopsy, when the biopsy report comes, there will be something grave which we notice at times. Even I had a biopsy report, it came as malignant melanoma after hemorrhoidectomy. It happened ways back when I was doing my PG. Classification, grade 1, which is inside, not coming out. Grade 2, coming out, but with it spontaneously goes in. Grade 3, coming out, but the patient has to put it in. And grade 4, it is permanent prolapse. In the initial presentations, there was something mentioned like history is not important. But this grading of hemorrhoids is based on history only. Don't try to look at the hemorrhoids and proctoscopy and tell, yeah, it is grade 1, yeah, it is grade 3. We all do that. No. Grade 1, grade 2, grade 3, grade 4, it is based on history only. Similarly, ODS, the diagnosis needs to be made. It is based on history only. So history is also equally important. Coming to etiology, because etiology, pathogenesis and medical management, that is the topic assigned to me. Increased abdominal pressure, upright posture and habits. So these three things you have to modify. Upright posture, increased abdominal pressure and your habits. Secondary causes I will mention here, but like inflammatory bowel disease, colonic malignancies, portal hypertension, they will be dealt elsewhere because the treatment of the secondary is the treatment of the cause. But for the primary, the treatment of the hemorrhoids should be done as well as we have to correct the primary causes. Increased abdominal pressure happens with straining. Some people spend some 20 minutes, 30 minutes in the toilet straining for stools. Don't do that. Constipation. If you are having constipation, use laxatives. Take care of your constipation. Dietary factors. It should be high in fiber, less of spices, more of water. And here I want to mention one more thing. These hemorrhoids usually happen after in cardiac patients when they go with a zero fat food. And once a patient told me when they get hemorrhoid, it is a very best thing which they have found is in night drink milk with a spoon of ghee. It gives a very good relief because the stools become softer and it goes easily. So avoidance of fat is something, never avoid anything. You reduce the intake of fat. That will be the best way in cardiac patients. Pregnancy, ascites, chronic cough, BPH, when you strain for urine. Prolonged sitting, maybe because of job, like software people, maybe because of some teachers, they have to correct the papers or something like that, shopkeepers or something, they may be sitting the entire day and they develop the complaints. Obesity also, because the weight damages the entire brunt of the weight comes in your bottom and it damages you. Prolonged straining, that is one of the habits which need to be changed. Never read newspaper, smoke, or do WhatsApp games in a toilet. Just like when we say, if you are eating, you concentrate on your food and eat. Similarly, when you are in a toilet, you are doing a work there. So you concentrate on that work and do it. Don't do otherwise, because if the stools are hard, you will not understand that. And the last being anal intercourse, which is there for females as well as males, which need to be addressed in the current era. Even if some people, even old people, those who are coming from villages, they tell they have constipation, so they finger and remove it. So anything which is hard going through the anal canal, we should be cautious about. The pathogenesis is being told is these anal cushions. Anal cushions are useful organs. They detect whether your stool is liquid or solid or gas. So if it is flatus, you gently pass it out. If you, before going to the toilet, you know that now I am having diarrhea, I should be very cautious. And when you go home, you run to the toilet and the stool is liquid. So your rectum is understanding what is the consistency of the stools. That is happening by the pressure the fecal matter is giving on to the cushions. Cushions are understanding that. So cushions needs to be preserved. And the prolapse of the cushion leads to hemorrhoids. That is one way of thought of that. Initial thought was the middle one. It is enlargement of the hemorrhoids. But nowadays, this is the principle. It is not getting enlarged. It is going down. So pull it up. Don't cut it from down. Milligan-Morgan happened by cutting this down. But here, pull it up. Don't cut this down from below. That is the principle, and it has given birth to stapler hemorrhoidopexy, hemorrhoidal artery ligation, suture pexys, Shivte's rectopexy. Every procedure, those minimally invasive procedures are based on this principle. Even the laser is based on this principle. Don't cut away the hemorrhoids, keep them, pull them, put them back to their original position. For evaluation, I think it was clearly demonstrated. Nothing to match your finger. Not even MRI. Even for fistula, whatever case, your finger is your best guide than any other modality. And preoperative investigations like ultrasound need to be done, liver needs to be assessed, as well as colonoscopy or at least a sigmoidoscopy is mandatory. Because bleeding can happen even from a cecal lesion. Patient is coming to you with a blood in stools. You do a hemorrhoidectomy, finally you are finding that the patient is having a cecal carcinoma or something like that. It will be, patients will not take it lightly. Conservative management, like a good sitz bath, at least 20 minutes, high fiber diet, avoid spices, plenty of oral fluids, regular exercise, avoid prolonged periods of sitting. Office treatments will be dealt with. Surgical procedures like hemorrhoidectomy, open laser, HAL, stapler, Shivte's procedure, everything will be dealt with. And there are a lot of hybrid procedures also. I welcome you all to WorldCon, which will happen in Cochin 3, 4, 5, 6 of April coming year. Today, if you, today, who all are fellows here, you will be given a code. With that, you can register for this coming month, and you will be given a 2,000 rupees discount for that. Thank you, sir. I usually send it. Every case, whatever, even if I pluck a nail of a patient, I send it for biopsy. Because it is a second person opinion of what you have done. Because later on the patient may develop any other illness, and then they will go to a doctor. He will ask, oh, this was, I will think it is a papilloma. I just removed and throw it off. That person will ask, what was the biopsy of the previous? How come you know that it is not a malignancy? You don't have any proof. Anything if you remove out of the patient's body, I send it for biopsy. Thank you.